Thank you, everyone. We will begin. Welcome to today's webinar. Dr. Mack, you may now begin.
Thank you. On behalf of the Morehouse School of Medicine's National COVID-19 Resiliency Network and our president, Dr. Valerie Montgomery Rice, we welcome you and thank you for spending your time with us today. First, I would like to thank you and all of our partners representing the African American, Alaskan Native, Asian and Pacific Islander, Hispanic, Latinx, Native American, disabled, refugee, Haitian, and many other disproportionately impacted communities that are part of this initiative. First, I'd like to give you an overview of the National COVID-19 Resiliency Network. This is an Office of Minority Health cooperative agreement. In July, a year ago, we were funded to do this opportunity with our partners, and we want to acknowledge the support of OMH. Our goal is to mitigate the impact of COVID-19 on vulnerable communities, on disproportionately impacted communities. Our objectives are 6 objectives: to identify and engage these communities, and you will see today the various partnerships that we have engaged across the nation; to nurture existing and develop new partnerships to develop an information dissemination platform. We are to develop culturally and linguistically appropriate messaging that can overcome the barriers and the mistrust among communities related to COVID-19 related services, and then to link communities to those services such as vaccination and testing, education, training. To monitor and evaluate this, to do the scientific research, we have scientific outcome measures that we agreed upon with OMH to measure the success of this platform and the impact of the platform on communities. And then, of course, to comprehensively disseminate the information through various forms of media. The cumulative efforts of this partnership will be highlighted throughout today's proceedings. We are particularly excited about the partnership highlight section, where you will hear from 4 INSERN partners representing diverse racial and ethnic groups. These presenters will share challenges and best practices related to behavioral health, social services, and the disabled and refugee communities. This will be followed by a breakout session in which we are looking forward to your participation and input. Before we begin, I would like to call our attention to the matter at hand. COVID-19 remains a challenge. People are still getting exposed, infected, hospitalized, and are dying from this disease. We must remain vigilant as we begin vaccinations in our children while we continue to study and protect ourselves against the variant strains. So please continue to protect yourselves and your family. Continue to encourage others to do the same, and keep pushing the importance of being vaccinated to your communities. Now I turn the program over to Dr. Akintobi, who's our strategic lead for community engagement. Dr. Akintobi is a professor of community health and preventative medicine and associate dean of community engagement here at Morehouse School of Medicine. And she also directs the Prevention Research Center. Now I present to you Dr. Akintobi to give you an overview of today.
Thank you so much, Dr. Mack, and thanks to everyone across the US and beyond who took the time today to learn from us, to learn from each other towards our collective efforts in COVID resilience. So I want to emphasize that this community exchange is focused on elevating your local leadership in all of the ways that you lead efforts to advance COVID recovery, whether that's in your roles as community health workers, clinicians, patient advocates. It takes all of us to turn the corner towards COVID recovery. So throughout the day, you will be hearing from leaders of our COVID Resilience Network. You will hear from partners who have been champions in advancing our efforts. And most importantly, we want to hear from you on what our network, our collective network, should keep in mind as strengths representing local efforts that you might be leading or participating in, and also the ways that the National COVID Resilience Network can be more responsive as it turns its page in year 2 of its efforts in COVID resilience. So please tee up your questions, your ideas, and all of the ways that we will work together towards COVID resilience. This takes all of us, and we appreciate your time today. So speaking of community partners, I'm very pleased to turn the baton over to Al Richmond, who is the Director of Community Campus Partnerships for Health. He represents an organization that is at the helm of bringing both academics and community leaders across the country and the world towards advancing health equity. So I turn the baton over to Mr. Richmond.
Thank you, Dr. Akintobi. It's a pleasure to join you this afternoon. I was so excited about this experience that I actually joined yesterday and felt like I was walking into a stadium. The door was open, but there was no one in the stadium. And so I was just so excited again about being here with you. It's been such a pleasure actually over the years to work with Dr. Akintobi on a number of projects. And certainly at this moment, this global pandemic has really brought us together in many ways to focus on equity, health equity. And certainly it has brought us together, all of us together. This is a moment like none other. None of us could have imagined over a year ago, 3, 4, 5 years ago, that we would ever be where we are today. And it's actually because of your work, the partnerships across the nation and across the world, and the great work that you're doing that really has allowed us to really advance community engagement strategies to reach the most vulnerable communities. I want to say a word about Community Campus Partnerships for Health and talk about who we are and our work. We are an international organization that focuses on promoting health equity and social justice. Our work is always done through partnerships between and among communities, diverse communities and academic institutions, but other groups and organizations that are working tirelessly in their communities to advance, again, equity and justice. In this moment of COVID-19, we have come together with a number of other partners through an initiative, the SEAL project that many of you may be familiar with. This is community engagement against COVID-19. I am fortunate to co-lead the project here in North Carolina. Dr. Akintobi and others, actually, Dr. Akintobi leads the project in Georgia. This was a project stood up last year by the National Institutes of Health to address the disproportionate impact of COVID-19 in 11 states that had among the highest rates or incidents of COVID-19. The project has since then been expanded to reach even some local municipalities that continue to be disproportionately burdened as a result of COVID-19. Here in North Carolina, the project, CCPH is fortunate to work along with the University of North Carolina Chapel Hill Center for Health Equity Research and the Maya Angelou Center for Health Disparities at Wake Forest University in a project entitled Increasing Trustworthiness Through Engaged Action and Mobilization. We are working in 3 communities, African American, Hispanic, and also Native communities. Our work has actually been expanded also to work nationally through the RADx Up, the Rapid Accelerating Diagnostics for Underserved Populations project. through the Coordinating and Data Collection Center, which is, again, a partnership between the Duke Clinical Research Institute and the University of North Carolina at Chapel Hill. Again, as I said, this has been a moment like none other. And for many of you who are working in community-based organizations, you know that firsthand, that we're being called upon to work in partnerships like never before. And so I think that this is a moment that many of us are thinking about: how do we galvanize the expertise and the knowledge that we bring to not just respond to COVID-19, but also to think about the future in terms of addressing health disparities more broadly that are so present in our communities. I want to highlight quickly one of those ways in which we're doing that. And I feel so fortunate and so blessed to be a part of this. As a result of our work with the Coordinating and Data Collection Center, CCPH is leading the engagement. Let me just go back and say I actually co-lead the engagement core with Dr. Krista Pereira. And we now are fortunate to be working with community partners in 2 cities across the U.S., Greenville, North Carolina, and Chattanooga, Tennessee, to roll out an in-home testing project. This is an effort funded by the National Institutes of Health. And this provides free at-home testing to individuals. These 2 communities were selected, again, Greenville, North Carolina, Chattanooga, Tennessee. We're working with community partners to distribute kits and free kits to reach the most vulnerable, those persons who are actually in the role of essential workers, those people who really are not able to stay at home and self-isolate, but individuals who really have to be out in the public through their work and through other activities. And so this provides them with free testing at home. This, I think, is a game changer for me. I think of it that we first were tackling the issue of testing, then to vaccine, and now we'll continue to focus on both of those. But this is a game changer in that it allows people to actually do testing at home. This product has been approved by the FDA, and so you should expect to see more advertising about this. But again, our project provides free testing. I want to highlight some of the ways in which our community partners are engaged. This is the key messages that we have been able to connect into with our community partners. These are images of many of them, and they have really been instrumental and have served in a major leadership role in helping to bring attention to COVID-19 and at-home testing. Again, these are images, these are billboards throughout Greenville, North Carolina. We will have similar outreach activities going on in Chattanooga, Tennessee as well. These are some of the billboard images. We have partners who are standing up distribution events. Some of these are in person, where people are gathering safely to distribute the kits, but also they are sponsoring drive-by events as well as pop-up events at grocery stores, businesses, and other locations where people are coming together. Certainly, the centering of this work is really faith-based organizations, specifically churches, that have really stepped up to distribute the kits not only to their congregations, but also to their communities. For that, we're so thankful. This is an image of a bus stop in Greenville, North Carolina, where the Say Yes signage is. So we've literally blanketed the communities with information about the at-home testing project. This is but one example of how community-based organizations and faith-based organizations have stepped forward in this moment to actually address COVID-19, not just COVID-19, but also more broadly health disparities. I want to encourage you to consider becoming a member of Community Campus Partnerships for Health. Visit our website at www.ccphealth.org and follow up with us as well. Thank you again for this opportunity to share what we're doing at Community Campus Partnerships for Health, which I think is complementary of the amazing work that you're doing in your local communities. Again, thank you.
Hello, I'm Arletha Livingston. I'm Assistant Professor of Family Medicine and Director of our Innovation Lab. Today, I'm going to talk about the community health worker mobilization effort. I will start off by just giving you a little bit of background about the CHW mobilization strategy. So, as we know, community health worker involvement is critical to any COVID-19 mitigation strategy and central to the INCERN response strategy. Working in conjunction with the National Association of Community Health Workers, other community-based organizations, and community health workers to implement and continuously evaluate the mobilization strategy. The INCERN CHW mobilization strategy consists of 3 overlapping phases. So, information gathering and planning, mobilization, evaluation, and research. During the information gathering and planning stage, the National Association of Community Health Workers team has completed an environmental scan and listening sessions to understand the national CHW COVID-19 response landscape. The results of the national scan were diversity of the CHW workforce, issues such as lack of CHW professional identity, COVID-19 racial and ethnic patterns were important, and similarities in county health ratings were also important information to discuss. In terms of the INCERN priority communities, some of the results revolved around COVID-19 rates and the response strategy, CHW infrastructure and engagement, CHW workforce challenges and opportunity, and mapping the new politics of care. The full report is available on the INCERN and NACHWA websites. This information helped CHW community health workers. The mobilization strategy fits into the INCERN COVID-19 response goals of nurturing existing and developing new partnerships, disseminating culturally and linguistically appropriate information, linking communities to resources with technology, and soliciting and incorporating feedback from communities. As such, the mobilization strategy involves hiring and training CHWs, capacity building for community-based organizations, community engagement and information dissemination, evaluation, and research. With the assistance of NACHWA, 10 community health liaisons were hired. The CHWs currently reside in Hawaii, California, Louisiana, Texas, Florida, and Georgia. The CHWs hired are experienced CHWs and were previously trained in CHW core competencies. The community health workers have received additional INCERN and COVID-19 information training, as well as information dissemination training. The hired CHWs are involved in community outreach and engagement. They are participants on the INCERN Community Coalition Board and Regional Community Coalition Board. They are advising and providing feedback on strategies and materials. They are disseminating culturally and linguistically appropriate information. They are engaging with other CHW community members, other CHWs, community members, and organizations in their focus areas. They are recruiting community members for focus groups and surveys. They are providing information and linkages to community members. They are distributing Comcast broadband connectivity vouchers to community members. The CHWs are involved in INCERN evaluation and research. They are facilitating focus groups with members of target stakeholder communities to determine cultural and linguistic appropriateness of materials and tools. They are participating in listening sessions with the Community Coalition Board to ground truth the state of public health infrastructure response among disproportionately impacted communities, and entering outreach and linkage to care information in our platform. We also have a Community Bridges CHW capacity building program for community-based organizations. We know CBOs are in position to make great impact on COVID-19 mitigation efforts. In the Community Bridges program, INCERN supports local community-based organizations in COVID-19 hotspot areas with capacity building, training, and technical assistance to support the mobilization of CHWs in local areas. CBOs receive training and technical assistance to develop CHW mobilization plans, including monthly webinars, access to online CHW training, technical assistance calls, mobilization plan implementation and evaluation assistance, a modest stipend, and Comcast broadband connectivity vouchers. Ms. Brittany Knott will speak more about the program this afternoon. In our breakout session today, we will speak with two CHWs about their roles in the mobilization effort and discuss issues relevant to CHWs. Thank you.
Good afternoon. My name is Rhonda Holliday, and I serve as the strategic lead for the Communications and Dissemination Core within the NCRN. We have partnered with the University of South Florida to offer our community partner organizations a training in community-based prevention marketing to affect social change through marketing. Dr. Mahmouda Pasha from the University of South Florida, who is the Associate Director for the WHO Collaborating Center on Social Marketing and Social Change, will now present to you more information about community-based prevention marketing. Dr. Pasha.
Hi, good afternoon. I hope you can hear me. I didn't have a chance to test my speaker, but good afternoon. So as Dr. Holliday mentioned, my name is Mahmouda Khalik Pasha, and I'm a faculty member at the College of Public Health at the University of South Florida. So I'm going to present to you our work on community-based prevention marketing. So my goal in sharing this information is to give you an overview of what exactly is this framework and how have we actually gone about applying it with the community partners, and to share with you some of the preliminary results that we have achieved as well. The overall goal that I have is that I would like to introduce you to this information, and you as community partners reviewing this may see value in this being something that you may want to adapt or may want to learn more about as you go on your work of addressing COVID or other public health problems in the community. So let me see, next slide. So as I mentioned, as part of the NCERN project, our goal at the University of South Florida is to build a community organization's capacity to develop culturally and linguistically appropriate messages to address COVID-19 testing and vaccine acceptance. And you may link this back to one of the primary goals that Dr. Mack shared at the very beginning, which was focusing on the creation and dissemination of culturally and linguistically appropriate messages. And so this framework is providing the foundational steps for us to get to that point of developing those strategies and go on the messages. So as I mentioned, the framework is community-based in its role, and it's called community-based prevention marketing. And I will say the short term CBPM, but it will be referring to community-based prevention marketing. So the framework provides foundational steps to community organizations to better understand how to target behavior and select specific groups of people from the larger population to work with. More importantly, this framework provides a structure for how to go about listening to our priority population or communities, and how to use this information to go about co-creating messages, materials, and strategies that reflect the values and feelings of the community. In the end, what we go about doing is achieving behavior change by developing tailored and customized materials for our audience. CBPM is a multi-step process that builds on the community knowledge. We use traditional qualitative and quantitative techniques such as key informant interviews, focus groups to understand public health problems such as COVID-19 and to glean key insights to go about encouraging behavior change. As part of NSERN, we have been working through the first 5 steps of this framework, and I will be sharing with you shortly some of the preliminary work that we have achieved thus far. So as mentioned, CBPM is a community engaged program planning framework comprised of 3 essential components. The first one is the community, and so that's the people who are sitting in the audience at the moment. The second is social marketing, which I'm going to define and share with you some additional information on in the next slide. And finally, together with the community and the application of social marketing, we go about achieving sustainable change or sustainable outcomes in our community. So you may be saying, some of you may not be familiar with what exactly is social marketing. Well, social marketing is the core component or ingredient of CBPM. Said simply, social marketing is the use of commercial marketing principles to achieve behavior change that is of benefit to the individuals and the communities at large. Key elements of social marketing include the focus on the consumer or the individual, or in this case, our communities, listening and understanding our communities by way of doing research, and then translating the research to create marketing strategy that helps to encourage behavior change that is of benefit to society as a whole. Main components of social marketing include targeting a specific behavior, selecting a specific audience, understanding the audience better by way of creating, say, a persona, and then the research. These main components align with the CBPM framework, and we have been working on these components as part of our work with the NSERN community organizations. So to date, we have hosted, since January, we have been working with community partners from NSERN network in working to improve the capacity to understand and apply CBPM. You will have a chance to hear directly from these community partners later on this afternoon during breakout 1. Where I have invited 4 of the organizations who participated in the training to share their experiences and how the experiences have translated to the work that they're doing in the field, along with what they're doing currently with NSERN. For the CBPM training, so far, we have run 2 separate cohorts and are planning for additional cohorts later in the summer and in the fall. The training consists of 6 interactive 1-hour sessions on social marketing, followed by practice building exercises that allow the participants to apply the concepts to the field at hand. Our very first cohort, as I mentioned to you, was in January and it ended in February. We had a number of organizations attend this session, or teams from the organizations, and you'll see the listing of the organizations here, such as the Association of University Centers on Disabilities, the University of Texas at El Paso, or the National Latino Behavioral Health Association. We had around 22 participants sign up and on average had around 19 attending. And our second cohort, which we just completed last 2 weeks ago, this had a very good representation from many different organizations, including the United Front of the Haitian Diaspora, the National Association of Community Health Workers, which you've heard a little bit about, and as well as the NYC Institute of Integrative Health. And again, in this, we had around 20 people signing up and attending on a regular basis. So now what I would like to do is to go about sharing with you what these organizations came up with. I'm not going to go in depth since the time is limited, but for you to learn more, you may want to come to our breakout session later in the afternoon where the organizations will share more about this information. So as we go through the social marketing process, as I mentioned to you, our key aspect has been to select a specific behavior and then a specific population, and then really get to know them better. And so, for example, here I'm showing you one of the exercises that was shared by the Association of the Asian Pacific Community Health Organizations. And their focus was looking at specifically vaccine uptake or completing the 2 doses. The barriers that they were looking at, or the reason people may not get the vaccine, was lack of confidence in the vaccine development process and lack of trust in, say, the previous presidential administration. And this was as it related to the priority population that they identified, which were healthcare staff in community health centers within the California region. And so one of the exercises that we do is that once we've defined the behavior and selected the audience, then we try to get to know who this person is. So it's not just a demographic, a female between this age, but get to know them. And so this is what this particular group did. They created a persona, and I won't be reading this to you. You'll have access to the slides, but they created Leila Santos, where they share who this person is, what her values are, what are things that drive her. It also shares information about what are her barriers as it relates to the behavior that we want to get across. It also shares information about how does she receive information and how will she want to receive information down the line if we are to go about creating an intervention for her. This is just another example from another community organization, and it was related to the Hispanic population. And here, their target audience was women between age 35 to 50 who are decision makers of their family health. And so this is a terrific, example. They came up with Consuela, and again, similar information shared about who she is, and the pictures giving a representation of what are her main drivers and who she is. And again, another one with the Hispanic population, more from the farm worker and meat packing, so from a vocational setting. And again, the behavior has always been COVID-19 vaccination and then the barriers. And then this is Anna that they created. And then here's from the population segment, from the African-American segment that was created by one of the organization. So Irene Smith is who they developed. And finally, I just wanted to share this last one. This was from the Haitian group that we had, and they were focused on Maria and how to go about reaching Maria. And an interesting aspect for them was that they looked at more religious leaders as a way to go about reaching this particular population. So in conclusion, just to share with you what are kind of the key insights or recommendations that we have found from engaging this process is that what the groups, communities have shared broadly, as summarized here, is that there seems to be a lack of confidence or trust in the vaccine development process or the reasons for the vaccine coming by way of the community. There seems to be a level of peer pressure amongst the groups, which then is a major barrier for whether someone gets the vaccine or does not get the vaccine. They've also shared that there's a mistrust of the medical system or the government. And then finally sharing that language presents an issue where materials and information are not available in the language that they need. And so that we may need to be thinking broadly about this. So in the large scheme of things, in terms of how we have gone about approaching NCERN, is that this is information that is informing our creative team or our marketing agency and the research team to go about developing the messages, materials, and strategies that are then going to be disseminated in the various communities that we all represent and work with. So I've just broadly shared, if you have any questions, you'll have my contact information as well as one of the doctoral students who's working on this project with us. And then I will move this on to Dr. Gagliotti.
Thank you so much. It's a pleasure to speak with everyone today, and thank you so much for your presence with us here. My name is Anne Gagliotti. I'm a family physician and associate professor of family medicine here at the National Center for Primary Care at Morehouse School of Medicine, and I serve as the research director for the National COVID-19 Resiliency Network. I'm going to speak with you just briefly today to introduce you to the network's research strategy and also talk a little bit about the data platform that we've developed to support the project. So the goal of the research core is to leverage the data streams and lessons learned via implementation of NCERN to generate evidence to mitigate the impact of COVID-19 on disproportionately impacted communities. And really our research strategy has three components. The first is to build a rich data landscape to support the project. The second is to conduct research and evaluation, both scholarly work and evaluate the impact of the program, and also learn how to continuously improve the project. As well as disseminate information to community members and disseminate the work that we do around research. Our research strategy has sort of three specific components around research and evaluation. The first is to highlight special populations and topics through collaboration with key partners. So we can really highlight the experience and expertise of community wisdom. The second is to understand both drivers of equity and drivers of disproportionate impact on communities. And we do that through building a rich data landscape, harmonizing that data across multiple levels. We know that individuals live in communities and families and neighborhoods, and that we need to harmonize data across all of those levels to really truly make meaningful change. And then the third component of the research strategy is to really understand the implementation and programmatic engagement models that we are implementing. We want to document what's been successful about building this coalition of partners and what implementation strategies were effective. And we also need to continuously improve. And so, as I said, the data landscape was a really important part of understanding disproportionate impact on communities from COVID. And so we wanted to build a robust infrastructure that was capable of evaluating the changing landscape of COVID-19. And we wanted to be able to do that longitudinally over time and at the neighborhood level. So we needed to build a data platform that was local, comprehensive, that was usable, that was able to respond to nimble definitions of communities and populations for quick comparisons. We wanted it to be interactive, and we wanted our community partners to be able to download data as well if they wanted to use that data for their own purposes. And so there was really a sense of democratization of the data that underlied this design. The design was also user-centered, and so we wanted to be sure that we were building something that met people's needs. The data platform team was made up of a great team from KPMG of private sector data scientists who had expertise in data scraping and modeling and data visualization, and then a team of academicians with expertise in health equity, population health, and spatial methodologies. And so it was a really diverse team that we leveraged the existing data structure of the KPMG Signals repository. And KPMG conducted an in-depth formative engagement process as well as iterative engagement around the data platform. And so they spoke with over 30 partners to sort of customize the types of data that would be available in the platform, how we would look at data at the local level or the small area, how the interactive platform would visualize data, and the specifics of how we would calculate different indices or models. We're excited about the potential of this platform and are hopeful that you will be able to join us for our breakout session later this afternoon. We'll give you a more detailed overview of the platform as well as the CHAMP survey that my colleague, Dr. Hopkins, is going to talk about in a moment. We're going to hopefully exchange stories about how data innovations are being used to support COVID recovery and health, and engage your wisdom around key questions of measurement of resilience and topic priorities. My information is here, as well as the information of my colleague, Ms. Rabab Zahidi, and please feel free to reach out to us with any questions about our work or about the data that we've compiled for NCERN. Now it's my pleasure to introduce Dr. Jamie Hopkins, who's going to speak with you today about the CHAMP survey. Dr. Hopkins?
Thank you so much, Dr. Gagliotti. It's a pleasure to meet all of you. My name is Dr. Jamie Hopkins. I'm an assistant professor in the Department of Community Health and Preventive Medicine at Morehouse School of Medicine. I also work in a research and scholarship capacity for the Satcher Health Leadership Institute, also at Morehouse School of Medicine. And I will be talking briefly and introducing you to our CHAMP survey, and we will have a more robust conversation during the breakout session. So just to kind of summarize, the true intent and goal of our CHAMP survey, which is the COVID-19 Health Assessment and Mitigation Planning Survey, is to keep a pulse on community. Again, there's a lot of assumptions of what is going on in different communities around vaccine uptake, attitudes and perceptions when it comes to the COVID-19 epidemic in general, as well as testing, vaccination, and other supports. Our intent and our goal is to collaborate with our vast array of community partners across the country to really assess and document what those community perceptions are, lived experiences, perceived and real gaps in care, and what the priority needs are of different communities across the country when it comes to COVID-19 prevention strategies, testing, vaccination, and care. And so just in short, what we truly want to understand is what is what we call the direct impact of COVID-19 on health and well-being in these communities? How do the social determinants of health interplay with COVID-19, and how is that a lived reality for our communities? If there are any disparities or if there are any differences in how populations are experiencing COVID-19 compared to others, and how do these attitudes, perceptions, and the insights, how may they inform our efforts within NCRN in providing maximal support and impact within our communities. Also want to stress that our CHAMP survey is not a one and done survey. This is designed to be an iterative process of exchanging information as it pertains to the development of the survey, how we disseminate the survey, and how we collect, manage, and make sense of the data that is generated from the surveys. So this is just a quick screenshot of the first product or the first tool that is within our CHAMP survey initiative, which is, we're calling it the Rapid Response Survey. This survey is directed to community members. And so it's a pretty broad, wide range of individuals that can complete the survey, essentially anyone over the age of 18. And we specifically want to understand more about the impact of COVID-19 within our NCRN priority populations, which are listed below. This brings a little bit of added value to this survey because we are uniquely interested in understanding and getting insight from these priority populations that oftentimes may be invisible or overlooked by other surveys and other polls that are out there looking at COVID-19 impact. I also want to stress that the survey is live. It's definitely been an ongoing process, and we are very excited that the survey is live, and you will have a number of opportunities throughout this webinar to complete the survey, and we encourage you to do so. So just in short, just a number of different themes and a number of different topics that you will find within the Rapid Response Survey. This was definitely an iterative process. We started off with about 75 questions, and now we have narrowed down to our first offering of questions, again, based on the input that we received from these questions and input from community. That will inform the other themes that we will investigate in future CHAMP survey tools. The last thing I want to speak to is our commitment to what we call equitable representation and data democratization. It is very important to us that this survey is broadly disseminated, and it is and that all community members have an opportunity to share their voice and to contribute to our process. So that representation and democratization is relevant for the entire life cycle of this survey, from how the survey was developed. Dozens upon dozens of partners and collaborators gave insight into what we should discuss and what we should ask, as well as how we should ask these questions. As far as the shared responsibility for disseminating the survey, again, it's going to require quite a bit of support to get this into the broader reaches of our communities across the country and make sure that folks have that opportunity to contribute their information. And then when it comes to the meaningful use of the information that the survey will collect, we really want to make sure that individuals that have an interest in understanding what we learn, making sure that that information is readily accessible, as well as the data that we are collecting, if it could have meaningful use for community action, community-led action in different regions of this country, making sure that we are doing our due diligence to make sure the data is accessible and there's a platform for active use. And so if you have any additional questions for the CHAMP survey, this is the information from myself as well as my collaborator, Lizette Badillo. We'll be talking more about the structure of the survey during our breakout session, Community Engaged Data Innovations. It's been a pleasure speaking with you, and I look forward to seeing some of you later on this afternoon. And next I will introduce Ms. Brittany Bethea.
You, Dr. Hopkins. Well, I'm excited today to share with you all a little bit about some of the digital technologies that we've been building in the last several months. Today, I want to share with you just briefly some of the key resources that are available on our website, which is also available through your mobile phones. So here is just a screenshot of our homepage. Ultimately, what you can find across our site is different resources that are related to COVID-19, as well as the other social determinants of health, such as finding resources around food security, finding resources around what clinical facilities are in your neighborhood, as well as mental health. You'll also see that we have a couple of different tools on the homepage that are accessible to help you as an individual or organizations help facilitate making sure that people are still monitoring their symptoms, understanding what the COVID-19 risk is in their area, and finding testing and vaccine locations. We also have the ability for individuals and organizations to join the COVID-19 Resiliency Network. By doing so, to subscribe, you join our email newsletters and text message campaigns to be alerted when there's new information about COVID-19 to share with your families or the communities that you serve. And then you can also create accounts to essentially get more tiered access to information, such as what's going on in terms of our regional community coalition boards. You can email or message members of our team or the network, and also just keep a general log of all of your interactions with us at the network. And then you'll also find that there are other features on the site that allow you to keep up with what news is happening. We have publications that are being released on a regular basis, and events like this that we're hosting here at the National COVID-19 Resiliency Network, as well as the events that our partners are hosting too. So here's just a couple of other screenshots to show you the depth and the breadth of what is offered across the site. One of the key features that we're really excited about sharing is that individuals and organizations have the ability to go in and search for resources based on where they live. So here in the middle of the page, it says search places. You can place your zip code, you can place your city, your state, or a full address to then see where are resources located in my community. There's also a resource library in the upper right-hand corner that allows you to search for different collateral like brochures or posters, or even digital resources like videos and infographics and other items that our partner organizations have submitted to share access with individuals and communities across the nation. Here's the list of publications that we've recently published in just the last quarter. We try to keep this updated every month so that you are aware of all of the new findings from the research that we're conducting, as well as the research that our partners are helping us conduct as well. One of the most exciting pieces of research that we have recently released in the last several months with our partners at the University of South Florida, as well as the organization ICF Next, is some of our insights from formative research activities with African Americans and Latinx populations, specifically from focus groups and interviews with individuals who work at organizations who serve those communities. We've also, with our partners, conducted a content analysis of different COVID-19 news stories and have conducted an audit with our partners at ICF Next on COVID-19 messages and materials. So we're looking forward to continue to iterate on our website, and soon you will also have the ability to access push notifications and other elements of our website via mobile app available in the Google Play Store and the App Store. However, the website is available by typing in our website URL, which is www.msm.edu/NCRN, and you can access the mobile version of the website as well. So next, I'll turn it over to Ms. Lisette Vadillo, the Program Manager for Community Engagement.
Thank you, Brittany. And thank you everyone for joining us so far. Like Brittany said, my name is Lisette Vadillo, and I serve as the Program Manager for the Community Engagement core of the project. And so now we will be jumping on to our partner highlights and to go a little bit more into the great work that our partners are conducting. And so let me go on to the next couple of slides. Okay, so for the next couple of slides, you're going to see the logos of some of our current partners. Currently, we are working with over 300 nationwide organizations. And out of these national organizations, we have a select few in which we are working closely with to accomplish the objectives and goals of the network, which and we call these organizations our strategic network partners. And from these select strategic partners, we will be highlighting 4 today who have been doing amazing work in the community. And they include the Association of University Centers on Disabilities, Alliance for Strong Families and Communities, the Center for Victims of Torture, and the National Latino Behavioral Health Association. And on your screen, you've been able to see some of the logos of our partners. I won't go into detail for each one of them, but you are able to go to our website and read more about the great work they are doing. And after our partner highlights, we will be breaking out into the different affinity groups to dive into deeper conversations about our priority populations. As you may have noticed on our registration page, we had a total of 10 affinity groups, but for today's conversation, we were able to select the top 5 categories. And so we will have an opportunity to dive deeper into some of the other affinity groups during our upcoming Regional Community Coalition meetings. And I will talk about the RCC a little bit more later on. And so without further ado, I will go ahead and pass it over to Ms. Denise Rozelle. And all right, I'm handing it over to you now.
Great. So I didn't get to do a mic check earlier, so can you hear me? I'm going to assume you're hearing me unless somebody tells me otherwise. Okay, I'm Denise Rozelle. I am the Director of Policy Innovation for AUCD, the Association of University Centers on Disabilities. Let's see if I can do that. Yeah. So, and we are, as Lisette said, one of the partners in the project, representing the disability community, if you want to look at it that way, and trying to make sure that we talk about disability in everything that we do, and include that conversation. So who is AUCD? Let me start with that. We are a membership organization. We support a national network of university-based interdisciplinary programs, every state and territory. And they kind of act as the bridge between the university and the community and bring resources. We do policy, practice, research, in service provision in some places, across the age span and across disability. So it's a very wide swath. It's everybody in the disability community. It includes, like, for instance, the 14 IDDRCs are bench research. The 52 leadership LEND programs are basically training for early career professionals. So occupational therapists, physical therapists, developmental pediatricians, people who are involved with people with disabilities. And then also self-advocates, those with disabilities, and particularly those with intellectual disabilities, and families, all involved in basically a year-long fellowship to learn about disability, so that when you go out into your field, you know that. You understand it from the inside, and you understand it from people who can understand it themselves because they have lived experience. And then the University Centers on Disabilities, as I said, at one in every state and territory, at least, since there are 67. And they're a resource within each community. So that's a little bit about who we are. Then let's go to what my purpose here today is, to talk a little bit about COVID and the world of disability, and vaccines and the world of disability. I have a lot of links in my slides, so the slides will be, I'm assuming, will be available to everybody afterwards, and you can go to those links. I'm trying to give you lots of resources and some research, but mostly resources, so that for all the community organizations out there, you understand how to connect in your community and what's already available out there that you can use in talking about disability and COVID, disability and vaccines, making things more accessible. There's lots of good information out there, and we want to make sure that it gets to people with disabilities in all of your communities. One of the things that we say a lot in my world is nothing about us without us. That is, people with disabilities should be included in everything that you do. And frankly, when you start including people with disabilities in that way, what comes in is applicable to everybody, basically. When you start talking in plainer language, that's applicable to everybody. So let's go on. These are a few things, resources on the disproportionate impact of COVID on the daily lives of people with disabilities. WHO and CDC have both recognized that there's an increased risk of being seriously sick or dying from COVID based on disability. There's scientific stuff out there. There's lots of reasons for that. Everything from, the physical proximity, how hard it is for people with disabilities, and particularly intellectual disabilities, to be separated and isolated. How you're always talking with service. You will often have a connect to service providers. So the whole separate isolating thing has been very difficult. Anyway, there's some research there. There's research on the increased mortality risk for people with Down syndrome. There's research on the increased risk. They went in and found, literally, it is developmental disability is has the third highest risk, people with developmental disabilities, the third highest risk of dying from COVID across all age groups. So if you have questions around this piece, here's the information. Let's talk about disability and vaccines. What we have seen, well, there are a number of things we have seen. People with disabilities are a part of every community, right? They are a part of the African American community, they're a part of the Latinx community, they're a part of every community. The refugee community includes people with disabilities. They are often overlooked. They are often silent in those communities. We may not hear from them as often as we should, and they have both the same and some unique needs. And so looking to see and involving people with disabilities brings out both the need, the similar needs, as well as the unique needs. And so looking at that is really important. The overlap in the communities. We talk about, I have it here as multiple marginalization. We also talk about multiple layers of oppression. So if you are an African American woman with a disability, you have multiple layers of oppression that you are dealing with, and it makes it significantly more difficult because you have other needs as well. the disability needs. And sometimes the communities and the disability community don't talk to each other as well as we all should. And I will absolutely own that as part of the disability community. Okay, so vaccine distribution, there have been issues in distribution, people with underlying conditions having a hard time getting it, not being clear about which underlying conditions are covered, people in long-term care facilities. There are many people with disabilities still in nursing homes. There are many people with disabilities living in group homes. Obviously, what we know about congregate settings, this is a significant problem. And then there's accessibility, and I'll talk about that in a minute. Accessibility is not just, is there a ramp? Accessibility is not just, do you have instructions in Braille? There are a lot more multiple layers that goes with disability to make vaccines accessible, and there's a lot of good information out there now for that. Disability support professionals, I actually want to touch on DSPs very specifically because there's data out there showing these are people who help people with disabilities to be independent. They may support living in their homes. They may support whatever it takes, helping people with disabilities to be more independent and more active in their communities. Excuse me. And we see already some lack of vaccine. We see some vaccine hesitancy within that group. So then understanding the communication and the language and the information that's being provided is also incredibly important. We call that plain language or easy read. It's a very specific, using simpler words to describe what we're talking about. Easy read tends to have a lot of visual icons with it as well. It's a certain reading level that makes it accessible to everybody. And as I said earlier, I think what we find with plain language and easy read is that most people want to use it. It becomes much easier to understand a one-page flyer that's not written, I'm a lawyer, it's not written in legalese, or it's not written in academic ease. Or medical language. It becomes much easier to read and understand, and there's a lot of good materials out there in that way, particularly for people with intellectual and developmental disabilities, but also for everyone. And then vaccine hesitancy, there's actually a couple of interesting new studies out that I have here as well. We've got a couple of new surveys around vaccine hesitancy in the disability community. And this is one of the places where the hesitancy is similar to what we find in other communities, but also some of that is unique. And I want to be sure and raise it here. When we look at the studies that are out now, the surveys, I would hardly call them studies yet because they're really not, they're opt-in studies or surveys, but one of them had 4,000 people, adults with disabilities, talking about COVID vaccines. What they have found overall is that 72% of people with disabilities who responded have had or are in the process of having the vaccine. That's great news, but there's 27% who either are not sure they'll have the vaccine or will not have the vaccine. And then they started drilling down to why that hesitancy exists. So one of the reasons has to do with the fact that there is no real data about how vaccines affect people with disabilities specifically. People with disabilities were not ruled out of the vaccine trials, but they were also not specifically highlighted, whether that be people, and particularly where there are people with specific disabilities, whether that be people with Down syndrome, or if you have people with who are immunocompromised from particular disabilities, or if you have people, a variety of disabilities, some of the rare disabilities. So it was not tested specifically on people with disabilities. So there was a real question about whether you should trust that data or not among the vaccine hesitancy, the group that's hesitant. There's a real question about who to trust in terms of who is your trusted expert. People with disabilities over the years have not trusted the medical model because, frankly, they have been abused by the medical model. There's been a lot of time when the folks, the physicians have been, and the folks who use a medical model to look at disability have tried to cure people with disabilities, have lied about what's being done to their bodies, have lied about what is good for people or what is not, have made quality decisions about whose life is more worth living than someone else's. And we've seen that during COVID, even during places where physicians have made decisions about whose life is worth living based on whether or not you are paralyzed, or you can communicate in the way that we all communicate, or whatever it might be. And we've seen that. So people are very hesitant based on who they hear from. And so doctors may not be the best people. Your personal physician may be the best person, or a specialist may be the best person, or somebody who is your service provider you might trust. But there's a wide variety there and a real problem. Additionally, well, that's enough on that one. Let me go to the next one. I think the next thing I want to say is that we need to look at access to vaccines, particularly for people with disabilities, but I think as everybody, access is a civil rights issue, and it has civil rights protections. People with disabilities are covered by the Americans with Disabilities Act, and the Americans with Disabilities Act applies to public spaces. Public spaces must be accessible. And that means vaccine clinics have to comply with the ADA. You have to provide reasonable accommodations. The vaccine clinics and things have to be physically and programmatically accessible. There's a bunch of good guidance out there, and that's why I was talking about the links earlier. There's guidance called the Vaccine Information Collaborative. The link is here, and it gives all kinds of examples of what needs to be done for people with disabilities to have access to vaccines. There's guidance from the Department of Health and Human Services Office of Civil Rights prohibiting discrimination, disability discrimination, and again, giving concrete examples, and that's from HHS, so it carries some weight. There's strategies and best practices from the Administration on Community Living at HHS for people with disabilities and older adults. There's a whole bunch of information out there. Things like, are people waiting a long time to get that vaccine? Are they waiting in line? Are you doing drive-through? Drive-through is not really going to work for many people with disabilities. Are you inside a retail establishment? Is it accessible? Is the scheduling accessible? Oh my goodness, we have had horrible problems with whether or not scheduling can be done, can be used. People who are blind can do scheduling based on a screen reader if you use a screen reader. And you don't want to force somebody to have to use somebody else to schedule their appointment. That really doesn't help move away from the hesitancy we're talking about here. So are you explaining? For people with intellectual disabilities, are you explaining how to schedule? Are you explaining what vaccines are all about? That's all hugely important. Okay, I want to make sure I get to the next couple slides. Here we go. Accessible information is part of any effective messaging campaign. My colleague is going to be talking, Anna Costalis is going to be talking in one of the breakouts about something we've done called Sleeve Up, which is a whole campaign, social media campaign around COVID vaccines, and particularly highlighting people with disabilities and their needs. Tuesdays with Liz is a YouTube video. It's 3.5 minutes long. It's done by my colleague, Liz Weintraub. And you can also go search on YouTube. She has an entire YouTube channel, but there is one on Sleeve Up, which is about what is a vaccine. And Liz is a person with an intellectual disability, and she explains it. And as we all know, we'd rather hear from somebody who's like us. That's what she's done there. You can search AUCD hashtag Sleeve Up on Twitter, Facebook, and Instagram for all that messaging. There's a bunch of good resources, again, in plain language, from the Center for Dignity in Healthcare. There's all kinds of new American Sign Language vaccine access videos that have been posted, that CDC has posted, and the link for that is there. There's the Autistic Self-Advocacy Network, which is autisticadvocacy.org. They have also a lot of plain language. They have a video on vaccines, just as we do. They have a bunch of vaccine handouts, one-pagers on what is a vaccine, why should you get a vaccine, and again, they can be used for people with intellectual disabilities, but they can also be used for anybody, whether they are again, somebody who may not have the educational level, somebody who may not speak medicalese. I've already said that one. And then last, I want to let you know. So I explained earlier who UCEDs are, the University Centers of Excellence in Developmental Disabilities. You can find the UCED in your state by going to www.aucd.org. CDC and the Administration on Community Living from HHS have been working to increase access in people with disabilities and to decrease hesitancy. There's been $100 million grants going out to about $4 million to USEDS, $100 million grants to address barriers to vaccination in people with disabilities, $4 million to USEDS, and they are specifically working in communities with communities to assist people with scheduling, to provide transportation, to provide resources, to do direct support services, to connect to in-home vaccination options. Check out the USED in your state and ask them what they're doing. Because if they don't know, they'll refer you to somebody, but they probably will know, and they may well be doing it themselves. I have raced through this, and I appreciate your listening. I appreciate you being here. I'd love to talk more. You had my email at the beginning, drozelle@aucd.org, and we are here to help and do whatever we can. Thank you.
Hello, everyone. I am Michelle Hinton, the Director of Population Health and Wellbeing with the Alliance for Strong Families and Communities, and I'm joined today by my colleague Saloni Gupti, who is an intern with the Alliance. She's studying global health at the University of Wisconsin. Today, what we're going to do is be providing you an opportunity to understand who we are and why we are a national partner with NCERN. Our goal is to talk to you about some things that we are doing as an engagement and dissemination partner, and share with you some things that are happening, as well as some things that we have on the horizon. So I'll first turn it over to Saloni so that she can share with you a little bit about who we are.
Thanks, Michelle. Like Michelle said, I'm Saloni. I'm glad to be here. And thank you, NCRN and MSM, for having us. So who are we? Alliance for Strong Families and Communities is a strategic action network of thousands of committed social sector leaders who are driving to achieve our vision of creating an equitable society through the excellence, distinction, and influence of our network. We have four main sectors: the population health and well-being sector, education success, economic opportunity, and safety and security. Our CBOs, or community-based organizations, are strong and committed to achieving a healthy and equitable society. These organizations are well-resourced and financially stable within themselves and the nation. These leaders reflect the racial and ethnic diversity of the communities that they serve. They have a strong, diverse workforce and a robust and extremely talented network. Their goals and actions reflect commitment to values, and they are creating and adopting innovative approaches to serve their communities and families. Collectively, these organizations drive equitable policies and systems. Our network is mobilized through a shared value-based policy platform. There's strong generative partnerships in the public and private sectors. They're involved in innovative research and private policy, and they enact and protect key policies by strengthening the families and support the strong, healthy communities. So why are we part of the NCRN? Like I said before, Alliance and COA is a strategic action network of the social sector orgs and CBOs. With that being said, we have about 1,500 organizations nationwide who are working to impact health equity through meeting individual social needs, and also systems creating through federal policy as well. Our organizations are working with the most vulnerable communities across the country, which, as we all know, is really important during these times of COVID. And ultimately, our goal is just to lift the voices of CBOs nationally as leaders that are impacting the social determinants of health. Our main goals of being part of the NCRN is to identify and engage vulnerable communities through local, state, territorial, tribes, and national partners. We also want to nurture existing and develop new partnerships while being part of this initiative to ensure that the NCRN is an active information dissemination network. With that being said, I would like to turn it back to Michelle.
Thank you, Saloni. So I'm going to talk a bit about some of the activities we've been involved with to date. And you'll see that, our organizations, the CBOs that are part of our network, have been really actively involved in some of the activities that you've heard from previously. When you heard earlier about the community engagement, about the community research, communications research, many of our organizations have been participating in those things. So we've done some key surveys focusing on members who are participating at local levels, who are engaged in COVID activity and engagement across their markets. We've been also recruiting for key informant interviews, as shared earlier with ICF Next, to really participate in that informative research. We've had some challenges, as you guys can imagine, due to COVID. Many of the CBOs across the country have kind of a hybrid way of working right now. Many of them have folks who are working from home and who are half are also in the office. So there's been some challenges in terms of accessing people. But we've been doing a pretty good job in being able to connect with our network across the country, focusing on those targeted markets and populations that's been defined by the project. We've also engaged with organization leadership who have been participating to help make sure we reach directly those staff that are focusing and working with communities directly. So those organizations who have community health workers and kind of patient navigators or community navigators. Those are the folks that we've been focusing on specifically to reach out to be engaged in these conversations, as well as participating in the research and surveys that have been happening through the network. I think I mentioned those surveys. You guys will see that the primary states that we focused on, we actually kind of assessed our network to define who across our network have community health workers. Those folks were, at the states that you have identified, see here. Among them, we identified that there were 10 organizations who have community health workers. And so then what we did is segment communication that came from INSERN to ensure that those organizations understand the opportunities that are arising as it relates to engaging those community health workers and training and COVID mitigation across their markets. Next, surveys. Get more surveys. I'm trying to figure out. Go next. You guys will see that our community outreach is around about 47 states. And so as INSERN provides us information to share with our network, we do that broad reach and using several dissemination practices to do that. We have some peer exchange networks that we host. So we have a variety of organizations that participate in these peer exchange networks. We also have an online learning community system that specifically targets COVID. And so folks who are looking for COVID information, asking questions about COVID mitigation, asking questions about, challenges that they're having in-house, we support ensuring that they have access to that information through INSERN and through our learning management system online. It's a pretty broad and in-depth community that many organizations across the country access to get information, real live time, real live information, and to also be able to access resources and toolkits and things of that nature. This is a recent article, a publication that I actually published an article in, talking about community benefits and the role that health systems and organizations can play in leveraging community partners to support community benefit plans in hospital systems. And we talked about, how they can build COVID mitigation plans through those partnerships. And in that article, I referred to the work that's happening with NCERN. I was able to share information about the work that's happening. And so if you have an opportunity, please feel free to check out the article. It is from the Catholic Hospital Association. So I think I mentioned earlier about the dissemination network that we have, all of the peer exchange groups that we have. We have online websites, social media presence that's clear, and email blasts and newsletters that we send out ongoing. We also launched a health equity webinar series where we're able to reach out to the network, to the NCERN network, and position the opportunity to lift up the work that's happening with the other national partners. So for example, upcoming, we have Denise, who will be presenting about the issues as organizations are facing that are partnering with the disability community. Recently, we learned through Dr. Waring at Tuskegee some real information around, the real truth about the history of medical mistrust. And so he also encouraged us to be mindful of the words that we use and avoid using hesitancy, the word hesitancy, versus understanding the mistrust that has happened as it relates to the history of how people were treated. And so being able to shine a light on Dr. Warren and the work that they're doing at Tuskegee was also inspiring. Again, not just sharing with our network through our national organizations, but also with the national partners that we have. So we have that equity series that we've been conducting, which has been really helpful to folks in understanding what's happening and how to really leverage this information to support their communities. We also have, in terms of coming up, I mentioned that we have Denise that's coming up in a few weeks. And then we're going to be doing another one on June 2nd that really speaks to, how people can truly partner with, community partners who are working with populations that are vulnerable to support mitigation overall. Want to also shine a light on some of our national partnership engagement. We have several national partners that we work with across the country, and they are listed here. Those organizations have been participating in our webinar series, staying apprised to the work that we're pushing out. They are also, we've also encouraged them all to subscribe to the website so that they continue to receive information. I have a standing opportunity on the agendas that I sit on these conferences monthly. I have a standing call with all of them where I'm able to update them on what's happening with NCERN. And so anytime there's opportunity or interest to anyone who wants to participate or share updates, feel free to let me know. These organizations are always open and available and ready for me to share or present to them about what's happening with NCERN. I'm also pleased to announce that we also have an amazing partnership with some social sector partners who are part of our network to host a More Than Healthcare podcast series. And so this podcast provides opportunity for staff and their organizations and others to really get some insight on best practices and policies and what's happening across our ecosystem as it relates to promoting health equity. And so we have two co-hosts that are social sector leaders who do interviews with organizations to kind of talk about those things that are happening. We're excited that we just recently interviewed Dr. Mack, and that interview will be available very soon, and we'll be glad to be able to share that with you guys also, that you can hear what Dr. Mack has to say. Again, as you think about the work you're doing as partners, if there's something you'd like to share or something you'd like the sector to know, feel free to reach out to me and we can get you scheduled for an interview. The last thing I'll note is that I think I mentioned earlier that we have some upcoming activities. We are going to look at, again, how we can better leverage our learning management system to really broaden education and awareness about the mitigation that's happening. We're able to share more about understanding populations, how we're able to share the information that NCERN has provided as a result of all of the research that's happening. So we're going to be looking at how we can better leverage this system to provide access to this information. We also want to continue to do interviews. I think I mentioned to you guys about the podcast. We have a great organization that's representing our network as a part of the Community Coalition from Texas, from Houston, Texas, Baker Ripley. They're doing a great job. And so we'll just continue to continue targeting our learning for our organizations and continue to disseminate the information as it becomes available. And really looking forward to being able to lift up the work that you guys are all doing. So I'll stop there and turn it over to the next presenter.
Hello, everyone. I'm not sure you can see me, but I believe you can hear me. This is Dr. Adobe.
Can hear you. Dr. Adobe, I believe you muted your microphone.
Can you hear me now?
It looks like you have muted your microphone again, though. That looks good.
Okay, but you can't see me.
We can hear you, but we can't see you.
Okay. Okay, I'll just proceed for the sake of time. My name is Dr. Adobe Hidru. I am a psychologist and clinic manager for the Center for Victims of Torture, and I'm joined by my colleague Dorothy Gaki, who is the outreach coordinator and health navigator for the Center for Victims of Torture as well. I will be talking with you all about the work that the Center for Victims of Torture does in Clarkston, Georgia, and some of the activities that we've done so far in regards to the NCRN partnership. So CVT is what I will use for short, and we are an international nonprofit that works with refugees and immigrants worldwide, and our goal is to heal the wounds of torture on individuals, their families, and their communities, and to end torture worldwide. How do we do that? We have different sectors of work that we do. What we're known for internationally is our healing work. We provide psychotherapy, case management, physical therapy, medical services across our locations. And the goal is to heal the physical and psychological wounds resulting from torture and war trauma. We also engage in training and capacity building with other organizations, international organizations, as well as local domestic organizations that provide torture treatment services to refugees and immigrants to strengthen and support their work in working with torture survivors. We also engage in advocacy for new allies and new resources to treat survivors and to end the practice of torture worldwide. We advocate here in the US, we have offices in DC, and we have advocacy work here in Georgia as well, and really across the country, advocating against practices that encourage torture as well as immigration practices as well. And we engage in research. So we do a lot of data collection, outcome evaluation on the work that we do that informs publications, empirically supported documentation around psychological services, and other services that support refugees and immigrants. So here are some of the places we work. I told you we are an international organization. We were founded in Minnesota, so that is where our headquarters is located, and we were founded in 1985. And we have our headquarters there with some other clinics. Then the only other domestic site is here in Atlanta. We are located in Clarkston, Georgia, which is a hub for refugees. And Clarkston welcomes thousands of refugees. Over the years, has welcomed thousands of refugees. And then we're located internationally as well. We have a program in Jordan where we work with Syrian refugees. We have a program in Ethiopia where we work with refugees from Eritrea. Have a program in Uganda, and in three places in Kenya, in Nairobi, in Dadaab, close to the refugee camp, as well as close to the Kakuma refugee camp as well. We partner with other sites that provide services to refugees across different countries, and some of our partner sites are indicated right there on the slide. Oh, and the numbers indicate refugees and families that we work with in those particular locations, the numbers per year. And so overview of what we do here in Georgia. We have a very small team, and our primary focus is on clinical services. Our team provides individualized confidential care as follows to refugees and immigrants alone. I want to be clear about that. We only serve refugees and immigrants, which includes asylum seekers, undocumented individuals, and any immigrant who wishes to receive services and has a history of torture and trauma. We provide individual and group psychotherapy, clinical case management, client services coordination, professional live interpretation. So we use interpreters for probably about 90% of the work that we do, and we only use live interpreters. We do not use telephone interpretation. Just because of the nature of the work that we do and the trauma experiences of our clients, it's in terms of best practices, it's just best to have consistency in who the interpreter is for each service that we provide. We conduct community outreach and health navigation, which Dorothy will speak a little bit about, and holistic care in collaboration with community service agencies. So we collaborate with medical providers, a lot of legal providers, because some of our clients are in immigration proceedings. So we support their legal cases. We provide testimony for their immigration cases when indicated, and support them through the immigration process. And then consultation on trauma-informed care with other agencies, and providing support to individuals to learn how to best work and intervene with this population. So Dorothy will go ahead and talk about the project activities that we've done so far, and then we'll have it back to me.
Thank you so much, Dr. Adobe. At this point, I want to take us through the project activities that we've been able to implement so far. We engaged in a community mapping exercise, whereby we have been able to come up with a geomap of relevant community resources for refugees and immigrants in Clarkston and surrounding areas. We've also been able to partner with Refugees Women Network to provide COVID-19 workshop educations to the community in Clarkston and other surrounding communities. And they were in Swahili and Arabic, and they were led by refugee immigrants, health providers. We have also been having ongoing community leaders interviews, whereby we had identified 5 communities, which are Congolese, Ethiopia, Eritrea, Sudanese, Afghan. And in these community leaders interviews, we've been having structured questions whereby we've been asking them their beliefs, their challenges, and any questions that they have, and also trying to identify current needs for their communities, as well as culturally and linguistic appropriate dissemination recommendations. We've also been engaging with community partners, and we have been very active in the Clarkston Community COVID-19 Update meeting that usually takes place every 2 weeks of Mondays evenings, whereby we get updates on anything that is related to COVID-19 in Clarkston and other health-related issues in Clarkston. We've also been able to engage the community through social media by sharing relevant information from NCRN and other issues that are related to COVID-19 on our social media platforms. These are some of the flyers that we developed in partnership with Refugees Women Network. One is in Arabic and the other one is in Swahili. We disseminated them to the community at large, and we were able to reach out to people with information in regard to COVID-19 related issues. Okay, some of the challenges and barriers that we encountered during our project implementation is that during the COVID-19 workshops that we conducted, we were not able to get as many participants as we had anticipated, simply because the immigrants and refugees, some of them were not just comfortable engaging with virtual interactions, and others didn't have really digital devices with them, and others also had poor network connections. Language barrier was also an issue. Some were not able to really understand, and some were not able to speak the language that we were presenting on. And there was also the issue of reluctance to participate in COVID-19 related issue due to the stigma that is related with the respiratory infections currently. And there is also the issue of the refugees and immigrants, some of them expecting incentives to participate. And we really don't have the capacity to do that when we engage with them. Lessons learned is that cares and fears of COVID-19 vaccine continues to be prevalent, simply because some refugees and immigrants are afraid of the COVID-19 vaccine due to negative experiences with vaccines in their home countries where they come from. And the misinformation regarding to COVID-19 has also led to the fear of being vaccinated. And also, we realized that most of them are living in their past experiences, whereby they're afraid to come out and experience some of the things that they went through from the regions where they came from in Africa. And I also realized that health literacy has been impacting the community at large, simply because some refugees and immigrants are not able to navigate the health system. And also the information that they have in regard to health is deeply derived from religious and cultural norms within the communities that they come from. We've also been trying to engage community leaders, as I mentioned earlier, and we've realized that engaging the community leaders, especially the religious leaders, is an effective strategy for combating any misinformation related to COVID-19. At this point, I'll handle it over to Dr. Adobe to finish up with the anticipated plans for the next phase.
All right. So I am going to talk a little bit about what we're planning for next. So we plan to continue community engagement and education in partnership with various individuals in the community and organizations that are already doing the similar work that we're doing. We will collaborate with community leaders. So as Dorothy mentioned, we're conducting formal interviews with community leaders of various refugee communities in Clarkston and in the areas that surround Clarkston. And this is guiding the development of culturally and linguistically appropriate healthcare information, which I believe is why we are on the INCERN partnership. So this includes developing flyers, posters, pamphlets The INSERN platform is great, is amazing, and the information there is relevant to the population. However, for the communities that we work with, the likelihood that they will access that platform is very low. And so the best way of reaching this community is by developing physical flyers, posters, tangible materials that we can drop off in local ethnic grocery stores and places of worship and where people gather, and trusted places as well. And in partnership with other local organizations, we'll coordinate and implement COVID-19 and health intervention activities within the community. One thing that we didn't include is we are also connecting our clients, because we maintain a caseload of clients that we provide mental health services to. Part of this project is to connect those clients to ongoing care, to test and to vaccine. And an example of that is with a family that arrived, I think maybe 3 months after the pandemic began. And they, within a few weeks, the entire family contracted COVID. And we had to intervene and provide support and guidance, and they didn't speak English, and just direction to how to get tested. And when the vaccine became available as well, providing support and access in the vaccine. And this involved Dorothy having to call and navigate with them and provide information about resources in the community, and offer to schedule the appointments and provide directions on how to get there, and support on how to access that service as well. So in addition to the community outreach work and education work, we're also doing that detailed one-on-one connection as much as we can, even though we're providing telehealth and virtual services at this time. So that's where I'll stop for now. Thank you. We are glad that we were able to share some of the work that we're doing, and we hope to talk some more about the issues that are facing refugee and immigrant populations in some of the small groups. Thank you. And I'll pass it on to the next partner.
Good morning. My name is Fred Sandoval. I'm the Executive Director for the National Latino Behavioral Association. I'd like to say many thanks to our colleagues at NSERN, the leadership team there, and to all of you for being here today. So I'd like to just highlight some work that we're doing here at the National Latino Behavioral Association so that we can actually attend to some of the most significant issues that relate to what is really happening in the Latino community. So what we see is a number of things that are taking place, right? We see that the number of cases and the number of hospitalizations and deaths affecting Latinos is so disproportionately high that we're highly motivated to address these issues. The way we're looking at doing that is to, in fact, look at those targeted states where these particular issues are impacting Latinos the most, given that in the top 12 states in the nation where we have the highest percentage of Latinos, California, Texas, and Florida absolutely represent that. And so what we're doing is engaging with local cultural brokers to tap into what we call the local expertise, because of the trusted relationships that these groups and individuals have in their local communities. It really brings to light the key insights and the context for the data that we just represented up on the screen. It also allows the new opportunities for participation in informative research. So what's important about looking at all of these combinations is understanding that we have both a macro, a meso, and a micro opportunity to look at these issues. So for instance, we know that in our national strategic partnership with Morehouse University, we've also turned to several other groups to help engage what we call with some of these efforts to address the mitigation of COVID and the effect it's had on Latinos. So the Con Alma Health Foundation, which was one of the first health equity foundations in the United States, its primary focus has been to be able to support us with some of the work that we've started to do here to leverage the resources with Morehouse University. The How Right Now campaign, also referred to as the Que Hacer Ahora national effort, is a community education evidence-based practice developed through the University of Chicago NORC Center. We've also participated nationally with the Pass It On clinical trial efforts to help address the absence of Latino participation in COVID trials. And our efforts there were to ensure that we had adequate and substantial Latino representation. So in terms of what's happening in relationship to social messaging, we've turned to ensure that our local communities, the cultural brokers that we've interfaced with as part of NALBA's Juntos network, which is across all 50 states, 2 territories, including the states of Texas, California, and Florida, we turn to some of the partners that we know who are highly trusted in their communities. Centro Campesino, which has been around since 1972, works primarily with farm workers in Florida. They have made every effort to bring resources to address the issues around food insecurity, the issues that have impacted those communities because of the impact of COVID, and the issues related to folks who have lost their homes because of the loss of income, employment, etc. So they've resourced their efforts at the tune of $2.4 million in a year's time to address those particular issues. They have worked consistently to ensure that there's ample food to help these families during these difficult times. As you can see, there's some images that we have presented here that relate to both the vaccination efforts that they're taking on in Florida. We also have some additional slides from Mano y Corazon, which is in El Paso, Texas. This is a border community that really represents a very unique part of the country. The border to Mexico, Texas, and New Mexico represents one of the most highly traveled international borders in the United States, and particularly in the globe. What we understand is the grassroots efforts by a group that we've been working with for many years, who was formed in 2012. Mano y Corazon Institute is very grassroots oriented. Their vaccine education efforts, their cultural imagery are represented through some of the social media materials that you see here. We had one posting alone that had over 25,000 views. So it tells us that with the proper culturally and linguistically appropriate social messaging, we can really message out to the Latino community, which is very diverse. All the kinds of things are important about understanding what to do regarding COVID. So my next slide here, one of the things we've undertaken is this education and information effort to help address the lack of information, to actually address the information that has been incorrect. So we've done a series of monthly pláticas. Pláticas is a Spanish word for conversations. So we have guests that we invite to participate in these pláticas. These are content experts, cultural experts. These are individuals in the communities, physicians, practitioners, public health leaders, policy leaders, et cetera, all who have come together to help us address these issues as part of a community exchange. And the whole idea behind that is to educate, inform, and to bring information about Latinos, for Latinos, and those things that are significant that impact us. This has been done not just through social media, but also through our webinars. And here's a couple of the examples that are here. The La Cultura y la Vacuna Nos Asegura social media ad was a great collaboration with our colleagues there in El Paso, Texas. I want to then show you here that we also do all of our work in English and in Spanish and in Portuguese. So this is a particular plática that we did with our esteemed colleague Lizette Badillo from NCERN, along with our esteemed colleague Ruth Yanez at our organization. I just want to read this quotation here very quickly because it really speaks to what we're hearing from the community through these pláticas. She says, "My daughter, who is 31 and had asymptomatic COVID, has made it her mission to get the whole family vaccinated. I'm so proud of her. Our elders are vaccinated. My generation is getting vaccinated, and hopefully my daughter's generation will get vaccinated soon." So this really speaks to what people are saying, what they believe, what's important to them about mitigating the impact that COVID has had on the Latino community. I'd like to go on to just share, of course, we're also touching base with the grassroots, the micro level of the work that gets done. The promotoras across the United States have been a significant part of our organization's effort through our Promotores de Bienestar training program, where we actually train individuals who want to become promotoras in order to help them address the community health issues that affect their community anywhere in the US. We included a COVID module in order to ensure that we get to incorporate that new information. And we partnered here briefly, as I'll share, with our colleagues at the National Association of Community Health Workers to talk about how we're training them. And that'll be offered in May and June of this year. Of course, we participated in the efforts for formative research activities because we want to ensure that Latinos participate in these processes. As my colleague said earlier, nothing about us without us, right? The focus group participation means is having representation that's equitable to our national population. 18% of the population of the nation is Latino, so it's important to ensure we have that kind of representation. We want to share with you something here quickly today, and my colleague Maxine Henry, the Associate Director for NALBA, was going to put in the chat box something really super cool. Turns out when we put this together, this was actually using this image along with a musical production called Vacúnate, Get Vaccinated. And it's a beautiful effort at how do we culturally message through music and artistry, the whole concept of something that Latinos can relate to, is how culture and those things that are meaningful to them help them really filter, assimilate, and integrate messaging. And so that information will be posted on here, and I'd like to ask you to listen to it there. It's only 1 minute and 55 seconds long. It's a powerful salsa message about what? Getting vaccinated. And so what I'd like to do is just highlight here very briefly that we'd like you to visit our website page, largely because it's an opportunity for you to visit our web page on COVID, the work that we're currently doing. We post all of our social media recordings, all of our pláticas, all of our webinars, all the social media ads that are posted there. The whole idea is how do we inform the Juntos network across the United States to really ensure that what we're doing is working together. I have to say here in closing that the National COVID Resiliency Network is a perfect term, a perfect title for describing the work that can be done across the nation at the macro, the meso, the micro level, the network, the ability for all of us to work across different groups, across different states, different boundaries, erasing all of those things that historically have been barriers amongst many groups for different reasons. The resilience that we are all demonstrating, as noted here in some of the presentations, it speaks highly to what we can do as a nation, as groups that are working at different levels. So I'd like to say thank you very much for the opportunity to share some of our work. We invite you to absolutely come look at our site and listen to our social media pláticas, because it's a way of hearing what the Latino community is saying, what we need, and what it is that we can take credit for in terms of addressing and mitigating the spread of COVID. So I'll stop there and now turn this over to our next presenter. Thank you very much.
We'll proceed with a 10-minute break. We're a little bit behind schedule, but we're going to keep with our break since this will be the first time that we have a moment since getting started at noon, and we'll return in 10 minutes. Thank you.